Hi there, this is Ben with HCO Thrive, and today I want to give an overview of our inpatient hospital quality data. Basically, we're going to give an overview of our aggregate data sets. All of the data is from CMS's Quality Compare. All of it dates back to the program or the data set inception, so when it was first released. Basically, we took all the data sets, combined them, and then cleaned them. So we got rid of duplicate values, added dates if dates weren't there, and pretty much created longitudinal panel data sets for your use. Over on the right-hand side here, you can see the data sets that we'll be covering. They're a combination of programs and then individual data sets that comprise the programs. So first up is the Hospital Acquired Condition Reduction Program. This is one of several CMS programs designed to incentivize inpatient hospital performance. More specifically, it incentivizes them to reduce the number of hospital-acquired infections as well as overall patient safety. Basically how it works, and we'll just go with brief details here. How it works is the bottom quartile or bottom 25% of all performers are docked 1% in pay. And as you can see in the diagram, it's made up of the hospital-acquired infections, which we'll talk about next, as well as an overall composite patient safety indicator. And these together form an overall HACRP score. Moving over to the data table on our website, here you can see, here's the PSI composite, it stands for patient safety indicator, total HAC score, and then common infections such as SSI, MRSA, CAUTI, CLABSI, etc. So basically what you have here, and then down below also there's payment reduction. So were they in that lower 25%? So really what you're getting is overall performance for an inpatient hospital over the course of this for a particular year. So this would be for fiscal year. This is the most recent. So this is for fiscal year 2025. And you can see the dates over here are the performance period. I just mentioned a large part of the HACRP program is hospital-associated infections. This data is collected by the CDC. If hospitals don't provide data, they won't get reimbursed. So that's how they ensure that they do report it. As you can see, some examples, CLABSI, CAUTI, MRSA, etc. These are some of the infections that this covers. Heading back over to our website, start with the documentation because the variable names aren't all that informative. But you can see that, 1A corresponds to CLABSI. You can see lower, upper confidence limits, central line days, eligible cases, numerator, standardized infection ratio, etc. So this documentation will give you a mapping for the variable names, and then you can see the data up here and date range, which is usually about a year. Here we have HCAHPS, Hospital Consumer Assessment of Healthcare Providers and Systems. You can see why it goes by an acronym, quite a mouthful. This is reported quarterly, so 4 times a year. And it is basically a survey given to a random sample of patients once they leave the hospital. Includes 3 different topic types, composite topics, which are heavily focused on communication, so nurse communication, doctor communication, responsiveness, and then also discharge and care transition. Individual topics, which is basically cleanliness and quietness, so sort of the environment around you. And then finally, global topics, which is an overall hospital rating, as well as whether or not you would recommend the hospital to someone else. And the way it works is basically these areas are combined into linear scores. Then those linear scores are transformed into the star ratings you see on Quality Compare. It's quite an involved process, so I can go over that at another time if you're interested. But for now, let's take a look at the data. And as you can see in the documentation, we have the star rating, linear score, and then each measure is broken down into the percentage of patients for a survey item that endorsed always. Here it's percent of patients reported sometimes or never. So it's basically broken down what was originally a 5-item measure, and then they're grouped into categories of, I believe, 3. And then you have linear and star ratings. And above, you can see the values. So for these are percentages. Then we have linear scores, and then the star rating on a scale of 1 to 5. Here we have the hospital readmission reduction program. This one's important because providers can be docked up to 3% of their DRG group payments. The way this program works is basically a model predicts a score for each of the readmission measures, as you can see below. So AMI, COPD, heart failure, etc. Then the actual ratio is compared to the predicted, and those who have actually more than what is predicted are penalized. This can be seen a little bit more easily with the data. So here we have the ratio, right? We have the values that go into the numerator and then the denominator. Some of them don't have denominators. Here we have CMS's Hospital Readmission Reduction Program. This is an important program as hospitals can be docked up to 3% of their DRG group payments. The way it works is CMS creates a model and then predicted versus actual rates for some of these readmission measures described below. So examples are AMI, COPD, heart failure, pneumonia, etc. So predicted is compared to actual, and if actual outpaces predicted by a certain amount, then the hospital will be penalized. Again, fairly complicated. I can go into the details at some other point if you're interested. This can be seen a little easier by looking at the data. So let's go over to our data table and take a look. So heading over to our data table documentation, here you can see some of the measures. So this is for AMI, heart attack, and you can see here's, so they have the raw numbers. This is the denominator. This is the numerator. So this would be the readmissions. This would be out of the total patients. This is what's expected. This is what's predicted. And then this is the actual ratio or excess ratio. And going up to the data, you can see that here. So finally, in terms of programs, we have the Hospital Value-Based Purchasing Program. This can dock hospitals up to 2% payment. It's going to adjust payments based on 4 different domains: clinical outcomes, person and community engagement, safety, and efficiency and cost reductions. In terms of scores, the hospitals get 1 for improvement over their baseline, so 1 for their own, and then 1 compared, an achievement score that's compared to all other hospitals. So 2 scores, whichever one is higher is their final score. And more specifically, the measures they're scored on are things like mortality and complications, healthcare-associated infections, patient safety, etc. So these are the things that make up many of the other data sets that CMS releases for inpatient hospitals. Here you can see achievement points, baseline rate, improvement points, and then the raw scores. So again, achievement is going to be based compared to other hospitals. Improvement is compared to themselves. Did they improve or did they not? And here the data is a combination of numeric percentages and then points out of 10 in terms of their achievement. One final note is that CMS keeps these data sets separate. So you'll have 4 different data sets for each of those domains. Here we just aggregate them all together. So it's one HVBP data set. And this goes back to the program inception. And over time, domains differed as well. So you'll see different domains as you go further and further back through time. Now we're moving on to readmissions, complication, and deaths. This is a combination of 2 data sets that CMS currently produces, 1 being readmissions or unplanned hospital visits, and 2 complications and deaths. For unplanned hospital visits, 3 types of measures. rates of readmission, measures of unplanned hospital visits after outpatient procedures, and hospital return days. For complications, for two specific types of complications, hip and knee. So surgery for hip and knee, patient has to return for something else. And then serious complications, which are measured by the PSI or patient safety indicators, which we mentioned earlier. Deaths are for serious issues as well. And those include COPD, heart attack, heart failure, etc. And looking at the data, you can see here we have complications from hip and knee surgery, mortality, dealing with an AMI, heart attack, and so forth. And then you can see the PSI measures that are used also in the HCRRP program. Timely and effective care data primarily measures procedures when a patient is admitted into the hospital. For example, how long is a patient spent in the ER, whether a patient was given aspirin if they are suspected of having a heart attack right away when they arrived, whether they're given beta blockers when they leave, as well as other factors such as whether or not healthcare personnel have had their vaccinations. Most of these measures come from patient records, whereas the vaccination records come from the CDC. And you can see some of the examples over on the right. And here looking at the data documentation, smoking advice, are they given the appropriate medication, etc. You can see overall volume here. Were they communicated to? Were they given discharge instructions? And here you can see the numeric data. Finally, we come to the other category, which is a collection of smaller data sets. Outpatient imaging efficiency is basically how effective, how efficient, whether or not there were duplicate tests ordered. MSBP, or Medicare spending per beneficiary, is just how much the hospital spends per Medicare beneficiary compared to other hospitals. And finally, the Veterans Administration, VHA data, is data specifically from the VA. And currently, timely and effective care and inpatient psychiatric facility measures are what is offered by CMS. In the past, there used to be others. There was surveys, patient safety indicators, etc., but not anymore. However, in our aggregate data set, we do keep all those data sets together. And so briefly, we'll just take a look at some of these data tables at our website. Here's the documentation for the outpatient imaging efficiency. So you can see outpatient CT scans of the abdomen that were a combination, breast cancer screening recall rates. And for MSBP, pretty simple. There's only one measure. So if it's over 1, it's going to be greater than average. Under 1, it's going to be less than average. And finally, VA data. We have some vaccination data right here, some outpatient efficiency, and these for the psychiatric inpatient facility. How often did healthcare workers have to physically restrain veteran patients? How many hours were they in seclusion? Measures like that. But overall, that'll pretty much do it. Let us know if you have any questions, and thanks for watching.